I'm looking at that thinking, okay, this is a piece of garbage. It's got so many small scissors. It has one needle driver, which is not even, it's a locking needle driver, but it's not good. I would go and grab an eye tray from the eye room, or from that stack just outside the ortho clinic, a lid tray. It has all the really nice stuff in it. I'm just wondering whether we should actually have one over here anyway. It's got the nicer instruments. They're used more frequently, so they're working and they're maintained. The nerve tray gets opened once in a blue moon. Our vascular pan has some long, fine needle drivers, which are designed for supposedly holding the tiny sutures, the tiny needles. We actually need to put in a smaller one because these drivers won't hold a 6/0 needle without it rotating. A whole lot of vascular clamps, and these are basically like a self-retaining version, a clamped version of a DeBakey tissue. So you can put it on a vessel, clamp it softly, and think about what you're going to do. There's we've got the angled ones, which are designed for getting into the awkward spots, and then we've got these ones, which you can put. This is, say for example, this is the blood vessel. You can go clamp on either side of the rupture and suture it if need be. I don't know any of our surgeons, Alex, Mike, Greg, might have a go at suturing a blood vessel.
You have
I've done one with Alex before, where he's put an artery back together.
Yeah.
But
If
it was
it's
like tiny.
yeah,
it was
if it's
like
teeny
little
tiny,
bulldogs
small
and
enough,
stuff.
they'll do what Mike did the other day and just clamp it, put a clip on it. The dark blue clip applier that Sarah normally uses for her mastectomies and everything, the ortho guys are using for small blood vessels now. I think we've got more than one now. I asked for ages ago for more. And this has some Stevenson's tenotomy scissors in it as well, which are thing. Most of the stuff, you'll have your working set of instruments open, whether it be a major pan, an ortho pan, whatever, and it's just adding to it. We've got, if they're suturing a blood vessel, they'll generally use a proline. They don't want to use a dissolvable braided suture, which your vicryl and your vicryl rapide, because that'll traumatize the vessel. So it's normally a smooth suture on a round bodied needle. So if you grab a cutting needle or a reverse cutting needle, you can't use it for blood vessels because it will actually just tear the vessel. The 5/0 and the 6/0 come with double needles, so you generally just cut them in half. And you just have to remember when you open them that it's 2 needles, not 1. For the bigger vessels, you'll use the bigger things. For that case with the knee, there was a big chunk of the popliteal artery missing. So, it was a big chunk. It was. We put because it went from the top across. It was quite a chunk, because it's like, okay, thankfully our locum general surgery person had just finished her training, and her last rotation was a vascular rotation, so she was able to put a purse string in either end, and we used a pediatric suction tube or a feeding tube as a shunt to bridge it, and we got a dorsal pulse, and we shipped them up and sent them off. We saved her life and her leg, but she has a very strong religious faith that it was God that did it all. Oh, I said, the surgeon don't get ideas. Yeah, there's not a lot a lot of it is having to think on the fly and work out, thinking, okay, what's the problem, what are we gonna do, what have we got? We don't have grafts. If we had Gore-Tex grafts or anything like that, they'd expire before we use them, and I don't know that we've got the surgeons with the skills that would feel comfortable doing something permanent like that. A great many of the vascular emergencies are treated in Emerge and stabilised and shipped out. We do have, and I've never seen these opened here, embolectomy catheters. And if someone's got a clot, like a blood clot or anything, in their leg, you pass the catheter down, blow up a balloon, pull it back, and it basically pulls the clot out and clears it. They're different sizes, and each one, the balloon is filled up with a different amount, and it says in teeny tiny letters how much liquid you put in the balloon. It has to be heparinized saline, because if the balloon ruptures, you don't want an air embolism floating through. And so you just grab the syringe of heparinized saline. I always check to see how much and fill it up ready. And in this case, this one's 2.3 mils below the balloon up. Some of them have guide wires, some of them don't. This one does. This one's expired, so you can play with it. And then you just coil it up, or if it won't coil, you just stick it in your big basin and place it down, or put it underneath the tray like that so that it doesn't spring off and go. This gets passed down, the screw on there. It also says on there 2.5. Oh yeah, 2.5 on there. And you blow it up slowly, and then you just pull it through, and it'll clean out. Basically, it's basically dredging any clots out. I've never seen them used here.
Where do you find them? They're
hanging as you go in the core. There's on the end of the ENT cart, there's a hanging thing, and they sit in there. Again, I would say it would be one of the orthopedic surgeons that would probably end up using them. If they had some congestion in a thing, or there was a clot. But I don't know if anyone else would bother using them. I don't know what else to say.
What about the bulldog clamps?
Oh yeah, well, we've got lots of different types of bulldogs, and they used to be in the set, and they got taken out and wrapped separately. Tell you how old these are. The plastic's disintegrating. These ones are quite firm, quite strong. If you just push them, and what you'll quite often see a surgeon doing is they'll be checking them to see just how much pressure there is, as to how much pressure they're going to put on the vessel. And that's where not that good. So Myra, they shouldn't be attached to this plastic. It's too thick and it puts too much strain on the joints. It could be attached to the piece of paper, but as we're pulling this off, this stuff is disintegrating and coming off, so you'll end up with it floating around through the patient.
Oh shit. Yeah, that's scary. Okay.
Yeah. I'm just trying to see if I can find one that's different.
That seems like a lot of pressure.
It is a lot of pressure. Here we go. That's how they should be stored.
No.
You want to touch it?
No. I'm not gonna be trying to.
And Maybe on the blood. That's-
Yeah,
Yeah,
exactly.
there we go. These ones are all slightly different. So it's a matter of just pulling the toes in to the room, and if they keep saying, no, this one's not good, this one's not good, just open them all. And once you've run out, that's it.
Again, maybe.
There you go. They're counted on the front of the count sheet. And last thing you want to do is leave one in the wound. There we go. So they're all different sizes and different
Take the bull's out with you.